Insurance barriers contribute to health disparities among commercially insured Americans. Appropriate use of prescription medicines improves health outcomes and quality of life for patients by helping to protect patients from out-of-pocket costs that hinder their ability to access and adhere to important treatments. Adequate insurance coverage for prescription drugs plays a crucial role in patients' ability to take their medicines as prescribed. Because more than 2/3 of Americans are covered by private insurance, 1. Health plans are critical to promoting equitable access to medications. However, extensive research demonstrates that historically underserved populations have lower utilization of and adherence to prescribed medicines for many health conditions, even if they have insurance. 2. 3. One reason that private insurance does not consistently facilitate access to medications is that socioeconomically disadvantaged patients often cannot afford the out-of-pocket costs or overcome other barriers imposed by their health plans. The impact of insurance design on underserved populations is considerable. Nearly 1/4 of families with private insurance live in poverty. 1. Because income inequality is closely linked with race in the United States, the impact of unfavorable commercial insurance benefit design disproportionately impacts people of color. For example, black households are twice as likely to hold medical debt as white households, a disparity that is not fully explained by whether they have health insurance. 4. Additionally, among patients with commercial insurance, Asian, Hispanic, and Black Americans are approximately 20% to 50% more likely than white Americans to be non-adherent with their blood pressure medications, and 35% to 60% more likely to be non-adherent with their cholesterol medications. 5. While a number of important social determinants of health contribute to inequities, one primary explanation for persistent disparities in medication access is health insurance benefit designs that increasingly shift prescription drug costs to patients. Increased application of deductibles and co-insurance to prescription drug coverage, along with other unfavorable features of many commercial health plans, create significant challenges with affordability of many medicines and the ability to fill and be adherent to prescribed treatments. High deductible health plans, HDHPs, can disproportionately harm economically vulnerable patients by exposing them to high out-of-pocket costs that hinder access and adherence to treatment. Enrollment in HDHPs is associated with lower levels of medication adherence for common chronic conditions. 9. For example, cancer survivors of all racial, ethnic groups enrolled in HDHPs are more likely to skip doses of their medications, delay filling prescriptions, and be unable to afford specialist care as compared to patients not enrolled in a HDHP. 10. Furthermore, these effects are magnified among black patients relative to white patients. Similarly, switching from traditional plans to HDHPs is associated with poorer adherence to cardiovascular medications across all racial, ethnic groups. 11 Health savings accounts, HSAs, paired with HDHPs can help to defray out-of-pocket costs for medicines. However, Black, Hispanic, and lower-income individuals are less likely to have or be able to contribute to HSAs, which may be attributed to structural causes, such as inequities in income, opportunities, and discrimination in the labor market. 12. Co-insurance, as opposed to co-payments where a patient's obligation is a fixed dollar amount, can pose a particularly challenging barrier to access for low-income workers, and people of color are disproportionately represented among low-wage earners. The share of health plans that use co-insurance for prescription medications has increased over time and is especially common for HDHPs. 13 Further compounding the affordability issues associated with these types of plans. In many cases, there are no caps on out-of-pocket drug costs per fill in plans that use co-insurance, leading to large and unpredictable Costs at the pharmacy counter. 0.14 Further, coinsurance is often calculated as a percentage of a medication's list price and may not reflect savings negotiated by the health plan. Formulary exclusions can have an unequal impact on patients who cannot afford to pay the full list price of medications not covered on their health plan's formulary or to navigate the complex and time-consuming exceptions process, which can require a high degree of health literacy. Although more than 30% of adults across lower to higher income cohorts say their insurance plan won't cover a drug that was prescribed by their doctor, the impact of these restrictions is greater among economically disadvantaged communities. More than half of low-income patients do not fill prescriptions for medicines that are not covered by their plans. 0.15 Utilization management and adverse tiering can have a significant impact on people who take medicines commonly placed on high formulary tiers are subject to prior authorization or step therapy requirements. For example, Black Americans are disproportionately impacted by sickle cell disease, but access to the newest treatments for this condition is often subject to extensive utilization management and adverse tiering. 38% of patients who were prescribed a new sickle cell treatment cited denial of prior authorization as the reason they failed to initiate treatment, and 70% of those who didn't start treatment cited some aspect of their insurance coverage as the reason. 0.17 Many common insurance design features leave patients unable to afford their medicines and disproportionately hinder access for disadvantaged communities. Follow our progress at phrma.org/equity2. Narrow or limited provider networks can make it hard for patients to access timely screenings and diagnoses, and they impose high out-of-pocket costs when enrollees use out-of-network providers. 40% of people who use out-of-network physicians do so involuntarily. 68% of these inpatient encounters are for emergency medical care, and half of patients with involuntary encounters faced unexpected costs for their care. 0.18 Even among patients who use a provider